Good morning, everyone. My name is Martel, and I'm very excited to talk with you today about a spotlight on acute agitation associated with schizophrenia and bipolar disorders and how we can make some improvements here. I am an emergency medicine faculty at Hennepin County Medical Center in Minneapolis, Minnesota. I've been a nocturnist here for about 20 years or a little bit more than that. My interests have been on managing acute agitation in our emergency department and in this very important population. And I'm excited to be presenting to you. I am being supported by BioXcel Therapeutics, and I'm acting on behalf of them. The information in this program is consistent with FDA guidelines, but the program is not CME accredited. I'll be sharing my individual experiences based on interactions with patients and others during my career. The conference today is really not intended to provide any medical or specific type of advice, and any treatment decisions you ultimately make or interactions should be up to your own clinical discretion, as each patient situation will vary. Our presentation today is going to be an overview of acute agitation associated with schizophrenia and bipolar disorders. We'll talk about current practices in the emergency care setting and the potential impact on patients, staff, and resources. We'll talk about current therapeutic options, discuss guidelines or recommended approaches to the assessment and management of acute agitation, and ultimately talk about translating to real-world practice and training. We'll start with an overview of acute agitation associated with schizophrenia and bipolar disorders. In general, agitation is characterized by both emotional signs and behavioral signs. The emotional signs and symptoms include hyperresponsiveness, racing thoughts, and emotional tension. Behavioral signs and symptoms that we'll see are the inability to stay calm or still, motor and verbal hyperactivity, and often communication impairments. Acute agitation is a behavioral emergency that's frequently associated with underlying neuropsychiatric disorders or medical conditions. Although the term agitation is commonly used, there's really no lack of consensus on the definition of what agitation is. I know that we've all seen this in our clinical practice. As a result, the clinical definitions and diagnosis are extremely variable. We see this with the number of different ICD-10 codes that are used to describe agitation. Acute agitation is very common in adults with schizophrenia and bipolar disorders in particular. Looking at claims databases and published databases, there are about 1.3 million patients diagnosed with schizophrenia in the US. Importantly, that's about 0.5% of the general population. Of these, about 25% of these patients will experience agitation at some point. There are approximately 6 million patients with bipolar disorder in contrast. That represents almost 3% of the general population. And of these patients, about 20 to 21% will experience agitation. If we start to distill or drill down in the numbers, on average, there are about 10 to 17 annual episodes of agitation per patient with schizophrenia or bipolar disorders. This is about 1 episode per month. If you do crunch the numbers, that means there's about 25 million episodes of agitation per year in these two patient populations. And as we know, this has been associated with a significant burden, not only for the patients, but the caregivers and the healthcare system in general. As far as looking at the etiology of agitation, there's no real unifying etiology or pathophysiology for agitation. There are several proposed mechanisms underlying agitation, and they include neurotransmitter imbalances, structural neuroanatomical changes, and possibly genetics associated with agitation and aggression. Neurotransmitter imbalance is mediated by dysregulations in dopaminergic, serotonergic, noradrenergic, and GABAergic systems. Frontal lobe dysfunction has been linked to agitation in patients with schizophrenia and bipolar disorders, and overactivation in the amygdala, coupled with inadequate prefrontal regulation, has thought to be defined as a trigger to increase the likelihood in agitation and aggressive behavior. There are some genetic thoughts that we have. Mutations in the catechol-O-methyltransferase gene involved in dopamine metabolism and catecholamine inactivation have been linked to agitation in patients with schizophrenia and bipolar disorders in particularly, but there's really been no gene for aggression or agitation that's been identified to date. So the thought of using genetic markers for risk prediction in order to mitigate clinical or injury consequences, or to determine the treatment or management of specific individuals really is still questionable. Patients with agitation can present with an extremely wide variety of symptoms, but extremely aggressive or violent behaviors are less common, as we know. There was a study performed in 2018 between October 2016 and January 2017 of 583 community patients living in Germany, Spain, and the United Kingdom with the diagnosis specifically of schizophrenia or bipolar disorder. Their data show that the most common signs and symptoms of agitation are restlessness, uneasiness, and nervousness. About 60% of patients experienced acute agitation associated with one or all three of these signs and symptoms. There's a wide variety of other symptoms that patients may experience, and this includes tremor, being unable to sit still, feeling irritable, feeling fidgety, wound up, feeling overexcited, a short temper, hostility, uncooperativeness, and a lack of control. These make up somewhere between 10 to 50% of the symptoms experienced in these patients. Aggression and violence specifically are the least common symptoms, though, and that makes up about 10% of the patient-reported symptoms. Many patients, though, reported experiencing multiple emotions and a variety of signs and symptoms. Like we said, acute agitation will commonly present along the spectrum, and this is from mild to moderate severity. But as we know in our clinical experience, this can rapidly escalate. A survey of the same 583 patients showed that 94% of their agitation episodes experienced by the schizophrenic and bipolar patients were reportedly mild to moderate intensity. And I think that's really important to note. Mild was defined as feelings that are uneasy to control or ignore by these patients, and that occurred in about 47% of the episodes. Moderate episodes were defined as feelings that are often harder to control or may get in the way of day-to-day life, and that occurred in about a third of the episodes. Moderately intense was defined as feelings that were seriously disruptive and interfere with day-to-day life, and those occurred in 14% of these patients. Only 6%, though, had severe agitation. And severe was defined by the patients as feelings that are almost impossible to control, and importantly, may lead to more serious outcomes like violent behavior or having to go to the hospital. So again, remember, this is from the patient's perspective. I think for us as healthcare professionals, if we're aware of the features of mild to moderate agitation, we can more reliably and accurately identify patients experiencing agitation and potentially treat them earlier. Most patients are aware of becoming agitated, and they do exhibit recognizable signs of escalation. Data from a 2018 study of self-reported signs and symptoms in patients with schizophrenia or bipolar disorders show that patients really had a good awareness of knowing when they were experiencing symptoms and knowing specific triggers. More than 70% of patients reported a good awareness of agitation, with 24%, nearly a quarter of patients, being aware always or most of the time that they were becoming agitated. 47% of the patients reported that they were sometimes aware of this. 61% of the patients, though, reported knowing specific triggers, like situations, events, people that led them to experience acute agitation. 15% of the patients reported knowing specific triggers always or most of the time, and 46% of the patients reported knowing triggers sometimes. That's a really good majority of patients. In a study of staff-reported incidents across 5 psychiatric hospitals in Australia, so these are staff reporting incidents of violence, there were about 1,289 incidents reported. 752 of them were rated as serious, and 82%, or over 600, of the serious aggressive or violent incidents were preceded by a warning sign, most commonly agitated behavior. Early recognition of these acute agitation and the warning signs of violence really indicates a potential for us to intervene early and work with de-escalation procedures. Obviously, and we've all seen this, if agitation is left untreated, the opportunity to calm cooperatively may be lost. Acute agitation, if it escalates, poses a sincere risk to safety and to staff and patients. In particular, emergency department staff are vulnerable to workplace violence due to the high percentage of acutely agitated patients with the potential for rapid escalation to violence or aggression. A really important survey of emergency medicine residents across several New York City hospitals reported that 66% of residents experience physical violence committed by a patient. Psychiatric illness was one of the most commonly cited patient-based factors and may have contributed to 92% of these incidents. That's really remarkable in my opinion. Another study in the psychiatric emergency rooms compared demographics and symptom profiles of patients with and without incident reports and found that a diagnosis of schizophrenia, schizoaffective disorder, or bipolar disorder with manic symptoms was associated with physical assault by an increased odds ratio of nearly 27.86%. That's remarkable, again, in my mind. Some of the current practices in the emergency care setting and the potential impact to patient safety and resources is what we're going to be discussing next. And we're going to start with a poll here. I'd like to get the audience's feelings on how you assess a patient's level of agitation in your practice setting. Oh, come on, guys, let's participate. Okay. Well, I definitely think we're seeing a pattern here. Most of us in the emergency department use general observation and an estimation of agitation when we're dealing with patients in the emergency setting. Standardized scales definitely are something that many of us have available, but certainly may be limited in our ability to manage them as we're working with patients in the acute setting. I think, as we know, assessing the severity of agitation is key to managing patients. However, it's really not standardized in practice. And to be honest with you, validated tools are used mostly in research. There are several tools available to us. Now, when we're talking about research and clinical trials, the Positive and Negative Syndrome Scale Excited Component, or the PEC, is probably considered the preferred tool for measuring agitation. Now, the PEC was adapted from a really well-established rating scale to assess the severity of illness in patients specifically with schizophrenia. It measures 5 symptoms: their hostility, poor impulse control, tension, uncooperativeness, and excitement. It's each rated by a clinician or another observer. The scoring is from 1 to 7. 1 is absent, 7 is extremely severe, and scores are tallied, ultimately giving you a range from 5 to 35. The BARS, or Behavioral Activity Rating Scale, was created to help assess agitation in clinical trials. I think it's often applied in practice as well. It's easy to use reliably, even for someone not trained in psychiatry or emergency medicine. It doesn't require the patient to answer any questions, and it can be used in the non-medical setting where decisions may be made by someone who's not medically trained. Similarly, the BARS is a single scale system rated from 1 to 7. 1 is difficult or unable to rouse, and 7 is violent, requiring restraint. Other common scales you may encounter in your practice or when you're reading literature on agitation include the Agitation and Calmness Evaluation Scale, or ACEs. It's a single item scale that rates overall agitation and sedation at the time of evaluation, as well as the Richmond Agitation Sedation Scale, which is the RASS. So when we talk about medications that are used in the emergency setting, antipsychotics and benzodiazepines are probably the most frequently used meds for management of acute agitation. The typical antipsychotics and benzodiazepines are associated with relatively excessive sedation and together account for more than 70% of the types of medications used. Although we're all shooting for a calming effect, excessive sedation has been noted, and it's been noted with a number of challenges, and it includes the higher risk of cognitive adverse events, difficulty thinking, etc., delays in patient evaluation and treatment due to interfering with collecting actual information, let alone useful information from the patient. It requires continuous patient observation, and as we know, none of us need increasing burdens right now on our staff. And it interferes in general with the patient participating in their care. And this certainly can lead to unfavorable treatment outcomes. About 80% of the medications that we use in the ED is given via the IM or IV route. Parenteral meds, honestly, are used sometimes just because of their quick onset of action. However, as with other medications, they've been associated with significant safety concerns. IM and IV administration of the meds can be painful for the patient. And to be honest with you, it's a very stressful situation for both the family and patients when we have to use needles. Parenteral administration of medications is accompanied by physical restraint in many cases. The combination of restraint use and inpatient treatment options can increase the risk of adverse events and lead to patient injury. Now, injuries can be across the board, and we know that there's a risk of respiratory suppression or positional problems with restraint, and rarely death can occur with restraints. And it's probably mostly in the pre-hospital setting. It's been reported in the in-hospital setting, restraint-related death from asphyxiation. We also know that if someone's restrained for an extended period of time, or if they're immobile in a catatonic state, thromboembolic issues can be a problem. There have been reports of fatal pulmonary embolism and thrombophlebitis being reported in the literature. And this suggests that immobilization may be a risk factor for injury and possibly even death. Even without harming a patient or causing physical injury, it's been reported that restraint use in patients can be traumatizing for them and can damage the relationship that we're trying to establish, a cooperative patient-provider relationship. Not only in the immediate phase, this might jeopardize future care when patients need medical assistance. A patient's restraint experience can be dehumanizing, and it can lead to feelings of anger, fear, and ultimately a loss of self-determination and freedom. These experiences, importantly, can lead to distrust of the healthcare system in general and medical professionals, and may cause patients to instinctively escalate in future visits when they come to the emergency department or an emergency psychiatric setting. Now, excessive sedation and restraint in using treatments that result in excessive sedation and requiring restraints obviously increases the resource utilization and can put providers and staff at a higher risk of workplace injury. In one study, the use of restraints was observed to be associated with a significantly increased length of stay. According to a prospective study of more than 1,000 adults with psychiatric illness, the length of stay in the ED increased by 36% if restraints alone were used. Obviously, the need for additional staff for the restraint procedure and subsequent observation is time-consuming, it's costly for the institution, and it prevents staff from performing other duties or caring for other patients in the ED. In addition, if patients require restraint or sedation, the agitation can be an independent factor that is challenging for admission or future transfer to other institutions. In another study, we look at the use of benzodiazepines and antipsychotics, having been associated with excessive sedation. Their use was linked to longer lengths of stay in the ED, I don't think this is a surprise to anyone. It's true in my experience. But in this study, the use of antipsychotics was associated with a 32% increase, functionally speaking, 4.4 hours in their length of stay, comparative to a length of stay in patients where the medications were not required. The use of benzodiazepines specifically was associated with a 23% increase, functionally 3.2 hours in their length of stay. We know that about 2/3 of patients' assaults on staff may happen during containment procedures for restraints, along with the greater need for resource utilization. An IM injection to a patient can increase the risk of needle stick injuries to our staff. Addressing agitation early while patients can still communicate and participate in their own care can help clinicians build trust, provide a broader set of management options, specifically oral medications, and potentially may reduce the need for healthcare resources overall. Now, what are our current therapeutic options? Well, you may or may not know this. There are only 4 antipsychotic formulations approved to treat agitation associated with schizophrenia and bipolar disorder. 1's an inhalation powder, and 3 are IM formulations. But as we know in practice, many off-label formulations are commonly used. Many of them are not approved. There are many other commonly used formulations that are not approved by the FDA, and they include both IM and oral formulations. I think it's important to realize, though, many of us choose antipsychotics because they also address the underlying disease, psychosis, mania, in these patients with acute agitation. We know that typical antipsychotics are believed to work through antagonist activity at the postsynaptic dopamine D2 receptors, and that atypical antipsychotics are believed to modulate dopamine and serotonin in the brain via antagonist or partial agonist activity at the postsynaptic D2 receptors and the serotonin 5-HT2A receptors. Benzos in practice are another commonly used medication class. However, they're definitely not FDA approved to treat agitation associated with schizophrenia or bipolar disorder. They are approved for medical conditions such as anxiety and sleeping disorders, but not agitation. They produce a sedative effect through their activity at the GABA receptor. They have a long record of efficacy for agitation and are often preferred by clinicians when the patient's known to be suffering from clinical conditions such as stimulant intoxication, ethanol withdrawal, or when we're just not sure what the etiology of agitation is. All right, I have another poll for you guys. What do you consider to be the best route of administration for treating acute agitation? I'm fascinated. Let's see if we can get a couple more responses. Okay. So it's about a 50-50 distribution on parenteral versus oral. I think that's really interesting. So obviously each route of administration has potential advantages and disadvantages. I think that's true for any medication. The parenteral meds have a fast onset of action, but again, the downsides is that they're invasive, they can hurt, and in many situations, they're coercive. The inhaled medications are certainly less invasive, and they do have the benefit of being a fast onset. However, there have been reports of bronchospasm and respiratory distress, and in general, many of our patients aren't used to using these medication formulations. There are several forms of oral medications that we have in our pocket to treat agitation. They're certainly less invasive than IM and IV oral. The orals are less invasive than the IV and IM. But in general, we're stuck with a slower onset of action. We know that tablets or capsules require cooperation, as with any oral formulation. The downside here is that they can be diverted. Patients can cheek them, and overall, oral meds can have erratic absorption. The oral disintegrating antipsychotics compared to standard tablets don't require liquid, and they don't require any actual involvement with swallowing. They're just rapidly dissolved, but they too have a slow onset of action. The non-invasive formulations, oral and inhaled, with patient cooperation, have the potential to really improve the patient's overall experience and hopefully help facilitate future cooperation with healthcare and healthcare contact. Although all of these medications can be effective in reducing agitation in some patients, there are potential limitations and safety considerations that we have to think about with all of the therapies. The three classes of medications are all associated with the risk of excessive sedation, and benzodiazepines generally have a greater effect with respect to sedation compared to the antipsychotics. The typical antipsychotics can carry a significant tolerability burden. As we know, there's a significantly increased risk of extrapyramidal side effects compared to atypical antipsychotics and benzodiazepines. In addition, the typical antipsychotics have a higher potential for adverse cardiovascular events. One of these includes QT prolongation compared to the atypicals. The atypical psychotics are now, more importantly, more commonly prescribed than typical antipsychotics because of their association with fewer side effects. Many of this is related to the motor side effects, dystonic reactions, and akathisia. However, the atypical antipsychotics are still associated with the risk of orthostatic hypotension. Although benzodiazepines may manage agitation, they certainly don't address the underlying cause of acute agitation, and they're associated with hypotension and respiratory depression, as we know. I think we'd probably all agree, and in my opinion, the antipsychotic of choice currently is probably haloperidol. All right, we have another poll here. What do you feel like the ideal characteristics or the characteristics of an ideal therapeutic for managing agitation? I don't know, it's not a trick question. I think in the grand scheme of things, we would all agree if we could find a single agent that really reached all of these properties, we'd be in great shape. Right now, I don't know that we have that available to us, though. So let's talk about guidelines or recommended approaches to the assessment and management of acute agitation. Well, the assessment is twofold when we're dealing with an agitated patient, and it includes medical and psychiatric evaluation for us to come up with a even reasonable differential diagnosis. Most of the time when we're triaging a patient, we would like to get some medical history, vital signs, perhaps a pulse oximetry and a blood sugar. This helps us really determine potentially the course of action early on. The patient's current medications, history of medical or psychiatric conditions, past trauma, and substance use can influence our management of agitation, and it's very nice if we have that available to us. Obviously, an early medical evaluation is really geared towards assessing for signs of substance abuse or withdrawal, head trauma, infection, and rarely, but also importantly, thyroid disease. An early or initial psychiatric evaluation often can be conducted just through visual observation and the reports that we get from the team or family members. Obviously, the goal of an emergency psychiatric assessment is to establish a reasonable differential diagnosis, not truly a definitive differential or diagnosis. When the patient is calm enough, though, a formal psychiatric evaluation should and could and should be conducted. Although difficult when we're seeing patients acutely when they have agitation, we'd really like to kind of determine a cause in order to establish a more tailored treatment. So without appropriate or early management, patients can quickly escalate from those mild to moderate levels of agitation to more severe symptoms. So initial evaluation really should include an assessment of the level of agitation, because our initial course, as we know, is really based on the severity of symptoms. Management of agitation often involves a combination of non-pharmacologic and medication interventions. And then patients with escalating agitation are more likely to need meds because they're going to lose their ability to communicate clearly. The uncooperativeness and verbal aggression really can get in the way and kind of start you down a path of more aggressive management. More stringent approaches are typically used as that severity level of agitation increases. In situations where urgent control of agitation is needed, clinicians may use higher dosing or prefer fasting acting IM or IV injections. And in this situation, patients are more likely to get restrained in the process and may become excessively sedated and requiring those more intense or more intensive monitoring sessions and longer stays. But regardless of the severity of agitation, prompt identification and intervention are needed to kind of help the patient regain their control safely and in a cooperative manner. Now, cooperative de-escalation is a process that may reduce safety risks while improving the patient's symptoms of agitation. In my experience, and I think in many of yours, de-escalation is a powerful tool, and it benefits both patients and the staff. Benefits overall may include improvements in overall safety, facilitation of patient cooperation, and ultimately us avoiding coercion. De-escalation can also be a whole lot more time efficient since the use of restraints is associated with an increased use of staff resources and time in the department. Additionally, adoption of de-escalation practices as first-line treatment for agitation has been associated with a difference in the percentage of emergency medicine residents being assaulted by up to 73%. Data from this study are based on survey results from a single county hospital in Texas, and they reported a drop in their rate of assaults from 28% to 7.5%, just a year and a half after implementing de-escalation procedures. Thanks, Len. Agitated patients presenting to the emergency department are at risk for escalation to violent behaviors. Project Beta, the best practices in the evaluation and treatment agitation, is a compilation of the best evidence and consensus recommendations developed by EM and psychiatry experts in behavioral emergencies to provide us guidelines that are safe, effective, and in the best interests of the patient. There are both verbal and nonverbal de-escalation strategies to assist the patients with calming down to cooperate with evaluation and treatment, and they're summarized by the acronym TEAM. TEAM stands for techniques which include both verbal and nonverbal, environmental and supportive modification, avoidance in the use of restraints, and coercive measures, and then finally M stands for medications. Combining these strategies can help facilitate appropriate patient evaluation in order to better understand and address the cause of agitation as early as possible in the patient's course. So I'd like to use the team approach by walking through a real-world patient situation that's presented by one of our BioXcel Therapeutic Speakers Bureau. This is a case that is probably familiar to many of us. This was a patient who was brought in by police for psychiatric assessment. It's a 30-year-old man who was homeless and brought to the ED. They reported that he was frightening passersby in the street with threatening gestures and verbal threats that he made. He was actively hallucinating with paranoid delusions, and he continued to be verbally threatening in the ED and specifically threatened one of the nurses. He really wasn't able to give any meaningful answers to most questions and carried on a conversation with himself. Many of the times he was just plain incoherent. He was hyper alert but oriented to name. He was pressured, he had a labile mood and elevated energy level, and was pacing in circles with his fists clenched. I'd like you to think about what your course of action would be, how you would first approach this patient. Now, as many of us do, we kind of get some background information, and in this case, they reviewed the patient's medical history and his workup. In the electronic record, he showed past visits to the ED. He had a diagnosis of schizophrenia, and had no active history of medical issues. On one of his previous ED visits, he was so aggressive that he was placed in physical restraints and given intramuscular sedation. During his visit, he was able to tell us that he had not taken any of his antipsychotics for an extended period of time. When you viewed the patient, he appeared well nourished, he was fully ambulatory, and we didn't note any other medical or psychiatric problems. They were able to do some labs, and his chemistry and blood counts were normal. His blood alcohol level was negative, and a tox screen was negative. They got some input from telepsychiatry, and the patient was determined to have an acute exacerbation of his schizophrenia with acute agitation. So to round out how this case was handled in the ED, their staff initially used de-escalation techniques to help the patient relax. They alleviated many of his fears, and he was able to see that the staff was there to help him and not hurt him. Fortunately, this emergency department had a peer support specialist on duty, and he was able to sit with the patient and engage him in conversation, and that was really noted to help calm the patient down. Importantly, the staff remained calm and communicative throughout the evaluation and treatment, and ultimately no need for physical restraint was necessary. The staff informed the patient that his medication, or that medication in general, is currently indicated now. They explained to him the risks and the benefits of the meds, and they were able to actually get informed consent, and the patient accepted oral medications voluntarily. I think that's a really nice example of how we would like many of our cases in the emergency department to go. And I think ultimately we're put in these situations, and we try verbal methods to help calm a patient, and they may fail. And then obviously meds are necessary. I think our goals ultimately of using medications is to calm patients without over sedating them. And that's so we can actually talk with them and make some diagnosis. If possible, patients should be involved in the selection of type and route and medication. And in my experience, I think that's really possible. And if a patient can cooperate and tolerate administration, oral medications are preferred over IM. I think in general, they're considered more humane. And the antipsychotics are probably preferred over benzodiazepines in these situations, mostly because they can help manage the underlying psychosis. I think simple things like offering the patient food and other supportive measures can facilitate their cooperation with taking medication as well. The timing and level of pharmacal intervention can be really crucial to the outcome of successfully managing a patient with agitation. We know that aggressive pharmacological intervention that results in patient being excessively sedated or asleep can mask underlying conditions and ultimately delay either medical or psychiatric diagnosis. Delays in medication can obviously allow the patient's agitation to escalate, and this results in putting the patient, staff, and others at increased risk of harm. But I do think we all recognize that although verbal interventions can work for some patients, medications are necessary for many. So how do we translate this into real-world practice and training? I think this is probably one of the more important surveys that we're going to take today. So I'd like you to weigh in on this poll of how comfortable you are with your knowledge of the management of acute agitation on a scale of 1 to 10. All right. So what I'm seeing from this survey is that probably what I expected, even in what's likely to be a very experienced group of clinicians in managing agitation out there, very few of us received significant training, adequate training even. Many of us have done this with on-the-job training, if you will, in learning about how to manage patients with acute agitation. And I think in this grand scheme of things, lack of guidelines or of decision-making algorithms We all experience suboptimal. I think there's a lack of guidelines or decision-making algorithms, and suboptimal education and training and limited clinical data have been kind of barriers that have been reported to improving agitation care. There's studies that say approximately 2/3 of physicians receive minimal or no formal training in managing agitated patients. And ultimately, in my opinion, there's a need for basic educational programs that teach providers to identify the simple symptoms and severity of agitation and to review pharmacological interventions. And there's a need for practical training on how to handle agitation in specific settings. Practical training should include verbal de-escalation techniques and tips for improving therapeutic alliance and when to intervene. There's an interactive website that's been developed. It's called partnersincalm.com. It aims to educate us as healthcare providers on the various signs and symptoms and levels of severity associated with agitation. The website provides educational resources to provide information on methods of managing agitation, to perform cooperative treatment approaches for this difficult to treat symptom. The resources include an agitation assessment tool. It's a helpful resource to identify signs and symptoms and assess severity. And there's a de-escalation strategy guide on the website, which provides a useful resource summarizing how to implement a cooperative de-escalation strategy in your practice using a team approach. In summary, acute agitation associated with schizophrenia and bipolar disorders can pose a significant safety risk to patients and staff, and it requires timely intervention. The selection, excessive sedation and restraint may increase safety risks and resource utilization and damage the patient-provider cooperative relationship. Selecting of current therapeutic option requires a balanced consideration of potential advantages and disadvantages of the route of administration, onset of action, and adverse event profiles. Timely assessment, cooperative de-escalation, which includes verbal and nonverbal techniques, environmental adjustments, avoidance of restraints, and timely use of non-invasive, non-coercive medication, ultimately may reduce safety risks while improving symptoms of agitation. And appropriate training and education may better equip medical personnel in the management of acute agitation. At this point, if there are questions from the group, I'd love to go ahead and field them. If we wanted to start a little bit of an interactive conversation, that would be great, using your questions. So I think one thing that many folks kind of talk about or ask when we're in some of the groups for acute agitation management, we talk about what are the meds that are practically used. I think we probably all have our preference in various situations. I think that in my experience, I tend to use the antipsychotics. My goal in treatment is to work with the patient to find the appropriate route of administration. Our group at Hennepin has really been, in the last 9 to 12 months, really coming up with strategies to work on oral routes of administration. We're frequently using some of the rapidly dissolving tablets in my experience. We also use some oral formulations of benzodiazepines. I certainly do have to admit that there are a number of patients in our population that require parenteral medications. One other question that I frequently encounter is how to manage de-escalation. And I think that it's probably the place where, in my experience, the vast majority of practicing clinicians feel as though they haven't had enough training. And I think that's represented by some of the information that we discussed so far. And I think the Partners in Calm website is a really great place to start when you're looking at verbal de-escalation. But I also think that significant I think that significant training is helpful if folks have something available through their institution. So first line, a question that sometimes comes out is what would be the recommended approach for patients with agitation who are schizophrenic or bipolar? And I think in my experience or in my opinion, obviously focusing on the underlying problem, the psychosis or the mania. I certainly think that antipsychotics are the first line in these patients. We're open for other questions. We certainly have a few more minutes that we could talk. I see a question on the chat about de-escalation. And if de-escalation fails, how do we handle this? I think that certainly a lot of support from your ED staff, using appropriate security personnel and staff to help cooperatively manage patients in this setting. A question that I'm getting across here is, where can I find more educational resources for managing schizophrenia and bipolar disorder? I think that there are a lot of opportunities to kind of grab educational resources. I do think that the website Partners in Calm is a great place to start, but there are a variety of other websites available from the emergency medicine and emergency psychiatry sources. Here's a question about my best choice in a crowded ED. So my best choice of antipsychotic or anti-agitation management in a crowded emergency department. To be honest with you, I don't know that's a completely fair question. I think it's whatever works best in your setting. I know in our emergency department, particularly as of late, we are crowded all of the time. I think that approaching an agitated patient in a respectful manner and very quickly bringing them to an area that isn't crowded. And again, that's likely to require IM medications with acute agitation when you're really concerned about patient, provider, and other patient safety. So it frequently requires removing them from this crowded situation the best you can. Actually, in our emergency department, when we have acutely agitated patients and we're overcrowded, we will actually bring them to our critical care area to manage them acutely. It's certainly the safest place to manage their agitation, do it in a collaborative fashion, have security available if necessary, and then to really help the patient gain control early. So in my opinion, it's to remove them from the crowded ED. And if that requires a critical care area, that's where I would go. All right, well, I really enjoyed talking with you today. This is a critically important topic. And I think that ultimately our goal, all of our goals, are to collaboratively manage these patients, avoid excessive sedation, and really hopefully get patients to where they need to be at the end of their ED evaluation. So I really appreciate your time today. Thank you to BioXcel for giving me the opportunity to talk about this with you. And I hope that we have some new therapeutic options coming in the near future to address this with all of those items in mind that we hope for. Thank you. Have a great day.